Welcome back to MediByte. Today, we're diving into another explainer on maternal and fetal health. We're going to explore the anatomy of two serious but totally manageable pregnancy complications, vasoprevia and placental abruption. Look, hearing medical jargon tossed around in the delivery room or during an ultrasound, it can be absolutely terrifying. But we all know knowledge is power, right? By understanding the exact mechanics of what's happening, you're going to feel so much more confident and prepared.
So a huge, warm welcome to all of you tuning into the MediByte channel. I'm your dedicated healthcare professional and guide for today, and my whole goal here is to take these kind of complex, intimidating medical conditions and break them down into clear, digestible, and empowering insights. We're going to walk through the whole shebang step by step to make sure you walk away with a complete and detailed understanding of your health.
Okay, let's dive into this and just quickly glance at our roadmap for today. First, what exactly is vasoprevia? Then, managing it safely. After that, we'll shift gears to understanding placental abruption, and finally, how we treat it.
All right, let's jump right into part one. What is vasoprevia?
To really wrap our heads around this complication, we first have to zoom in on how the baby is connected to its life source inside the womb. Vasoprevia is basically a condition where the membranes containing those incredibly delicate blood vessels, the ones connecting the fetus to the placenta, happen to cross right over or sit right next to the opening of the cervix. And the cervix, of course, is the entrance to the birth canal. Think about that placement for a second. These vital vessels are literally sitting right at the exit door. As you can imagine, that creates a super vulnerable situation when it comes time for delivery.
Now, what's really interesting about this is the stark anatomical difference. Normally, the blood vessels between the baby and the placenta are safely bundled up in this thick protective armor, the gelatinous casing of the umbilical cord. But in vasoprevia, those vessels are totally exposed. They're just running completely unprotected through the thin membranes surrounding the fetus. So when those membranes rupture, which is exactly what happens when a mom's water breaks right before labor, those exposed vulnerable blood vessels can easily tear. And if that happens, the fetus can lose a massive amount of blood really fast, leading to huge risks for both mom and baby.
I know, that sounds absolutely terrifying. But before you let panic set in, you gotta realize that vasoprevia is actually quite rare. To put that into perspective, we're talking about it happening in only maybe 1 in 2,500 to 1 in 5,000 deliveries. Plus, it's a lot more likely to pop up if there are already other abnormalities present in the placenta, which means your doctors are usually already on high alert and keeping a close eye out for it.
So how do we actually know if it's happening? Well, the hallmark symptom of vasoprevia is, surprisingly, painless vaginal bleeding right when the membranes rupture, usually as labor is kicking off. The baby's heart rate will also typically drop and get kind of slow because of the blood loss. But obviously, the absolute best case scenario is catching it way before labor even starts, right? Doctors can often spot the warning signs during routine early ultrasounds. To confirm it for sure, they do a transvaginal ultrasound to get a nice, clear, close-up look at those blood vessels crossing the cervical opening. It really acts as a crucial, life-saving early warning system. Moving right along to Section 2, Managing Vasoprevia Safely.
Let's move to and see how this builds, because once we have that early warning, we pivot immediately from diagnosis to action. A highly structured safety net gets rolled out. Starting around 28 to 30 weeks, doctors kick off non-stress testing once or twice a week just to keep a constant check on the baby. Then, between 30 and 34 weeks, they might actually suggest putting mom in the hospital to keep an even closer watch. During this time, they'll usually give her corticosteroids. This is an absolutely brilliant medical intervention that rapidly speeds up the baby's lung maturity just in case they decide to make an early arrival. Finally, if there are no sudden surprises, a cesarean delivery is carefully scheduled for between 34 and 37 weeks. Make no mistake, with vasoprevia, delivery is always, without exception, a C-section.
But hey, even the best laid plans need a backup, right? The medical team will drop that timeline in a heartbeat and do an emergency C-section if certain triggers pop up, if vaginal bleeding won't stop, if the amniotic membranes rupture early, or if there's even a hint that the fetus or mom is in danger. Boom, they head straight to surgery. It's a hyper-monitored, strictly protocol-driven process, designed 100% around safety.
Okay, let's jump to Section 3, Understanding Placental Abruption.
Now that we've got a solid handle on vasoprevia, let's transition over to our second complication. While placental abruption also deals with the placenta and definitely has severe risks, the actual mechanism of what's going on is entirely different. Placental abruption, or abruptio placenta, is the premature detachment of the placenta from the uterine wall happening at 20 weeks or later into the pregnancy. Normally, the placenta, which is literally the baby's lifeline for oxygen and nutrients, stays firmly glued to the upper part of the uterine wall until after the baby is born. But in an abruption, it peels away way too soon. This doesn't just cut off the baby's supply of oxygen and food, it also causes the mother's uterus to bleed internally.
To ground us with some context, premature detachment of the placenta happens in roughly 0.4 to 1.5% of all pregnancies. And this detachment can be incomplete, like sometimes just 10 to 20% peels away, or it can be a complete, full separation. Kind of wild, but in a lot of cases, the exact cause of why it detaches just remains a complete mystery. And this brilliantly illustrates why the symptoms can sometimes be so incredibly tricky to figure out. When the uterus bleeds from the spot where the placenta detached, well, that blood has to go somewhere, right? In an external hemorrhage, the blood passes straight through the cervix and out the vagina, making it super obvious. But in a concealed hemorrhage, the blood actually gets trapped behind the placenta. Because of that trapped blood and all the internal pressure it builds up, a mother might feel severe, non-stop abdominal pain, and even go into shock that seems way worse than the visible amount of blood loss would suggest.
Because the bleeding can be sneaky like that, doctors have to look really closely at other symptoms and risk factors. The main red flag is sudden, continuous, or crampy abdominal pain, plus tenderness when you press on the belly. Mom's blood pressure might also tank dangerously low, sending her into shock. Now, there are certain risk factors that make an abruption more likely. We're talking about high blood pressure conditions like preeclampsia, older maternal age, physical trauma like an abdominal injury, or the use of substances like tobacco or cocaine. Oh, and blood clotting disorders or having had an abruption in a past pregnancy, those significantly raise the risk for sure.
All right, final section, number 4, treating placental abruption.
So how do the pros handle this when it goes down? Just like with Vasa previa, you can rest easy knowing modern medicine has rock-solid protocols for this exact crisis. The game plan heavily depends on how far along the pregnancy is and just how bad the symptoms are. If it's preterm, meaning less than 37 weeks, and the bleeding isn't immediately life-threatening, and the baby's heart rate is totally normal, the go-to move is hospitalization and intense, round-the-clock monitoring. This lets doctors keep an eagle eye on things and jump in fast if the situation changes. And yep, just like before, they'll often administer those amazing corticosteroids during the hospital stay to fast-track the baby's lung maturity, just in case an early delivery becomes unavoidable.
So the crucial point is knowing exactly when to step in and act definitively. Delivery gets greenlit as soon as humanly possible if the bleeding continues or gets worse, if the baby's heart rate gets wonky, which is a huge sign they aren't getting enough oxygen, or if the pregnancy is already at term, meaning 37 weeks or more. If a safe vaginal delivery just isn't in the cards under all that stress, an immediate C-section is performed, and in really severe cases where massive blood loss causes shock or serious clotting issues, mom will get treated with blood transfusions and be watched like a hawk in the ICU.
Wow, okay. We've definitely covered some incredibly heavy, serious medical territory today. But as we wrap up this explainer, I really want you to ask yourself, knowing the specific risks, the exact symptoms to watch for, and the timelines your doctors use, how can understanding these placental complications empower you to advocate for better prenatal monitoring? See, this knowledge isn't here to scare you, it's a tool. It empowers you to ask all the right questions during your ultrasounds and to speak up immediately if something just doesn't feel right. At the end of the day, you are your baby's first and most important advocate. Thank you so much for hanging out with me today. I really hope this deep dive into Vasa previa and placental abruption has given you the clarity and the confidence you absolutely deserve on your healthcare journey. If you found this valuable, smash that like button. Share this, actually, scratch that. Make sure you share this explainer with any expecting parents who might really benefit from it. And don't forget to subscribe to the MediByte channel for more clear, no-nonsense medical insights. Until next time, stay informed and stay healthy.